I'm Ann O'Grady. I'm Director of Behavioral Health at Independence Blue Cross and have the pleasure of facilitating this great conversation with these amazing panelists today. Before we begin, I'm supposed to let you know that you can log on to the Sligo app using the event code or the QR code. And that will enable me to see questions at the end of the discussion. So I'm going to try to do my best to kind of work between my little paper notes and my iPad here. Really excited to be here to talk today kind of about how we get, we've now sort of really made a lot of progress with access, and we are now kind of fortunately at the place where we get to talk about how do we put access and quality together. Just a little bit of framework, we all know that about 50% of people diagnosed with behavioral health conditions actually seek treatment. And few of them kind of are receiving true sort of outcomes-focused care. So we really want to talk about how we move the needle kind of on that today. Before we jump in further, I'm going to let the panelists introduce themselves. So I'm going to turn to you, Deb, and let you start us off.
Thanks, Ann. Hi, everyone. Deb Nussbaum with Optum. I am Director of Evidence-Based Services. Thank you for joining.
Good morning. Brianna Duffy from Carillon Behavioral Health. I play a dual role, both as our external market president and interim president writ large.
Good morning, everyone. I'm Taft Parsons. I am the Chief Psychiatric Officer for CVS Aetna.
And Christina Safran, co-founder and CEO of Equip. We provide virtual evidence-based eating disorder treatment to folks across the country, covered by many of these awesome partners.
So we're really lucky to have kind of both a panel of payers, but also kind of a founder and somebody with lived experience in Christina. So as we start to talk through kind of getting beyond access to quality access, and while it's fantastic that we're seeing more treatment options, we know it doesn't necessarily translate into quality. So Christina, I wondered if you would kick us off just to get us started and talk a little bit about your experience with subpar care.
Yeah, absolutely. So for folks who haven't met me, I often joke that I've been in eating disorders for my whole entire life. I was diagnosed with anorexia when I was 10 years old and struggled throughout my adolescence. And I talk about the fact that I had a whole lot of privilege in a lot of ways, good insurance, parents that could afford to pay the cost that insurance didn't cover. I fit the stereotype of what we think eating disorders look like, which essentially meant that I got treatment sooner. And yet, with all those privileges, I still had a pretty horrific care experience, which unfortunately is the norm for folks with eating disorders. I spent my entire freshman year of high school, not in high school, in and out of 4 different hospitals for a total of 7 months. And when I got out of my last hospitalization and inevitably started to relapse because I didn't know how to take care of myself at home, nor did my family. Doctors said to my parents, send her to a long-term residential facility across the country. Don't have a lot of hope for recovery. People don't recover from eating disorders. And I'm very glad that they didn't listen to that advice and dove into the research. This is now 2 decades ago, and found out about family-based treatment, which we now know is the leading evidence-based treatment for kids and adolescents with eating disorders, that essentially realizes that eating disorders require you to fight your brain many times a day. It's not only ineffective, but kind of mean to ask people to do that on their own. And so it empowers the healthy folks in the household, very much chosen family philosophy, to structure the home for pro-health behaviors. And I always say it was the single hardest year of my life, but undoubtedly the thing that brought me into recovery. And very quickly in recovery learned how grossly inaccessible this field is. 80% of the 30 million Americans who struggle with eating disorders don't get treatment. So I've really been on a mission to change that and ensure folks had access to treatment. I started a nonprofit focused on this mission, and interestingly, as a teenager in this space, was raising a lot of money for ineffective treatment. I saw people just cycle in and out of facility-based settings and just not know how to keep themselves healthy and well at home. And so that's what really sparked this passion around it's really not enough for folks to have access to any treatment. They really need to have access to treatment that works and keeps them better. And frankly, I think it's unjust and really inhumane that many of my peers who I was in treatment with at 13 spent the next decade of their lives not in high school, not in college, cycling in and out of facilities, not building friends, relationships, hobbies, interests, like reasons to drown out their disorder and want to get better before they or their family ever heard about family-based treatment, the leading evidence-based treatment. And that's what I really hope that this panel can start to have a discussion about.
Great. So I wonder if payers might talk a little bit about the struggles that we experience in ensuring kind of quality, that access really equals quality. How do you distinguish sort of accessible care from accessible quality care? I'm looking at you, Deb.
Thank you. Thank you. Give me the easy ones, Anne. Thank you. Our benefits allow people to have in and out of network coverage. People can choose where they want to go to care. The insurer, the payer's responsibility is to cover care that is medically necessary. In the definitions of medical necessity, do you ever see measurements? What is needed to show that that treatment is helping? What measures symptom cessation? That's something that the payers really struggle with, because if we deny care, oh my God, you're the big bad payer, you don't want my child to live. But if we approve care or our customers allow us to manage the care, managed care is not a pretty term that anyone in this audience, I'm sure everyone hears managed care and they don't think that's a great thing. But there's a lot of clinical evidence behind managed care. We are looking at the systemic outcomes of hundreds and hundreds of treatment programs. I happen to know who the best programs are, but do people really want to hear when their child is in crisis? Do they want to hear that this particular program is better over this? From a member's perspective, we are the insurance company trying to save a buck. So we have to get past the notion of what the payers can do and what we can't do, and get down to transparency. We do pricing transparency, but we don't do outcome transparency. And that's where this industry really, really needs to go from my perspective.
Brianna, do you want to weigh in there?
Sure. I think setting the stage, we're going to go on an assumption that everyone in the room believes that measurement-based care is the way for us to proceed forward. And so that's just a guiding assumption we're going to use. We also realize that that probably means that not everyone in the room is actively using measurement-based care to its fullest perspective. And so what we're talking about today is really trying to figure out what the appropriate glide path looks like and includes to help make sure that measurement-based care does become more of a treatment modality norm, and that we do have the ability to capture what's ultimately needed data to show that from a payer perspective, a big piece of what we do, and to your point, Deb, is we try to help facilitate matching individuals who have a need and the best care that's available to them. And so we can do that through data, we can do that through analytics, we can do that through conversation, but we know that until we can really have rich data that is as accurate as possible, that some of that matching doesn't necessarily occur in the way that we need it to. And what we want to be able to provide is not just access to care in a timely manner, but we want to provide access to care that actually helps people get well. And that we believe that when someone is encountering a behavioral health practitioner, they need hope. They need hope that they're going to feel better from whatever it is that's bothering them in the moment, and that there needs to be a pathway to get well. And we really believe that measurement-based care is one of the critical elements in making that happen.
Thanks. Tab, do you want to weigh in on barriers? Anything more?
Sure. So, I will certainly say, I think this is probably, to some extent, preaching to the choir. This is a group of folks who are generally tech forward. This is a group of folks who, like to come to the payers and say, look at the wonderful data that we have to give to you guys to prove that our program works very well. What I will say is that, in the hundreds of thousands of providers that we have in our network, there's a significant portion of them that are kind of the single shingle, kind of we call mom and pop type of providers who, not only are they probably not documenting in any sort of electronic health record, but they also don't have things like somebody at the front desk to answer phones. A lot of times it's just the clinician, and if they're in session, they don't answer the phone. And so, this is kind of the headwind against us, where we're working to try to get all these providers who I do think really deserve to have a very fair shake in us kind of, judging, how evidence-based and how objectively good their treatment is, but they don't have the capability that a lot of the companies here in the room have, which is, good, capable, current EHRs that can set up APIs that transmit data back and forth with payers. One other challenge is that, I don't think that to this point we have complete consensus on what good quality care really is. We, the payers right now, we get a lot of data about a very limited set of things. So we get claims, it's like units of service. So we know units of service in an outpatient setting versus units of service in an inpatient setting. And so when we judge who's good and who's not, a lot of times it's looking at things like, did this member who's going to this outpatient provider end up in an inpatient setting, therefore costing more money and having higher utilization? And that's a very limited way to look at how good or not the care is. We're starting to get some, providers that can transmit things like PHQ-9s and GAD-7s and some of these other measures, which are great. They're required for evidence-based care, but it's not synonymous with evidence-based care. So you do have to measure things in order to do evidence-based care, but the fact that you are measuring things does not mean that you are providing evidence-based care. And we don't have a great way to truly measure whether or not when that our member, your patient, goes into the office, virtual or brick and mortar, are they actually getting evidence-based techniques in the treatment?
So I'm going to use that as a good segue to double-click a little bit more on outcomes-based measures, and what role do they play in ensuring that people get the treatment that works. That's perfect setup there. I'm going to stay with you, Taft, if we could. So what measures are you looking at? And kind of if you could say a little bit about how you are coordinating or kind of how innovative funding models sort of are kind of tying into outcomes-based or measurement-based care.
All right. Thank you for sticking with me. My kids say that I like to hear myself talk a lot, so happy to do that. So I think, there are certain kind of patient-reported outcome measures that are fairly ubiquitous at this point. So everybody collects PHQ-9s. Everybody collects GAD-7s. One of the challenges is as we get into specialty sort of care, like the care provided by Equip, is like, what are the measures that are really indicative of evidence-based care being provided to patients with eating disorders, adolescent patients with eating disorders? And that kind of funnel gets very narrow as you kind of go into subspecialty populations. And this is where I think we have a challenge, is because the folks at Equip, who are digging through the evidence about family-based treatment, they may be using a different set of measures than another company who says, well, we're more traditional, we do residential treatment, and here's our evidence that we do great residential treatment. And if we're not kind of singing from the same hymnal, so to speak, on what is good care, it's very difficult for a payer to judge Equip versus a traditional residential brick and mortar program. And so we have this big problem in behavioral health of not having that real consensus about what measures should we really be looking at for particular disorders to judge whether or not the care is good and of high quality. And I think that's a challenge that we're getting a little bit better at dealing with. We have ways to kind of intake a lot of measures through APIs at this point. But the challenge is we still, even if we get a particular measure from one provider, we don't necessarily get it from all the providers working in that space. And so that creates the issue of how do we compare one provider to another and make a really good recommendation to our members on who's actually providing the best treatment.
Great. Can you just say a little bit more about how you're using measurement and funding models?
I can start to talk about that. So I think, on the behavioral health side, we are significantly behind the physical health side in doing more advanced contracting and using value-based care contracts. So we are in, I don't know, maybe not infancy stage, but maybe toddler stage in this sector of healthcare. And so we are, looking at what are the things that our company values for our members to get. For quite some time, it was access. So, if you got access, you could get a little bit of a enhanced payment. We're moving on from that, setting up frameworks where the gate of entry is going to be the ability to data share. And so, and it goes beyond kind of like, every 90 days, can you present to us a PowerPoint slide deck? It's, can you set up an API and transmit data back and forth, and are you willing to do that? And that's kind of like the ground floor of being eligible for these types of contracts.
Terrific. Thanks. Deb, Optum, the big payer in the room here. Can you tell us a little bit about how you're using clinical outcomes, patient-reported outcomes, or measurement in any regard, kind of in your funding models?
Sure. So we used to call this pay for performance, where we would collect outcomes, we would see patients get better, and then we would offer value-based arrangements. That's still how it works with Optum. You have to join the network. You need to have some of our members in care for a period of time so we can collect the data, and then we get your baseline data. And we see how you're doing across diagnostic categories within regions. We do comparative regions. If you have enough members, if we can get enough baseline data, then we could build a value-based model for you where we're looking for indicators that you can improve on, and based upon those improvements, you can earn extra payments. So that's how the value-based modeling works. We can't value-based model everybody because you need to have volume. You need to have patient volume so that we can track and trend over time. We need a year worth of data, and every time I say that, providers go, "Oh, a year worth of data? No, that's forever. We want that value-based model now," and we can't. We need to have the data. We need to know how you're performing before we could tell you where we would want to expect you to go. And it can't be artificial. It can't be Deb saying, "Hey, improve on this and this, and we'll pay you more." So we're also looking to the evidence to say what is going to drive the best outcome for this particular condition, and in this case, like eating disorders. And Equip is on a value-based model for us. So thank you for that.
Great. Brianna, any comments there?
I think I'm well represented by my colleagues. I think we've got a lot of similarities in the way that we're approaching the work. And what you said, Deb, really resonates for me. And I just want to underscore, we realize that the necessity of the provider community is that we have folks at different stages of readiness, different stages of adoption when it comes to technology. Everybody matters. It's not as though someone is more important than the other. It's that as we are thinking about how we engage, how we pay for care, how we do things, there do become differences. And I think that's really what you were talking about, Deb. So again, really just very similar to what you both talked about. So thanks, Deb.
And can I just add two things on measurement?
Yeah.
The first is that, I get really optimistic with folks in this room that we really are pushing the field forward in this way. And so, you talk about us versus another provider. And my team has been really pleasantly surprised to see, we've all worked with you to set up value-based contracts where we're using the clinically validated modalities. We're coming to you to look at what is the relapse rates, what are the readmission to higher level of care rates from a cost effectiveness standpoint. And I've started to see some of our competitors start to report on data. And that makes me really, really happy. So I think it's a really positive thing for folks in this field. Like, we have the opportunity to show the field what good looks like in our different industries. And then the hope is that, you can say to other customers, like, look, this is the gold standard and here is what I expect you to adopt. The second thing is where I think that I love the distinction you made between evidence-based care and measurement-informed care. They are in the same family, but not the same thing. And I really think about, all of our providers are trained in evidence-based treatment. Measurement-informed care ensures that evidence-based treatment is doing what we want it to do. Like, we need to have a goal in treatment, and our providers, most importantly, need to be looking at that data on a regular basis with their patients and families and saying, here are the goals we set, here's how we're doing against them. And frankly, I am the biggest proponent in the world of evidence-based treatment. We know that it's not going to work for 100% of people, and that's how you know
Right.
it's not working. Let's shift based on the data we see. Let's try a new approach.
Yeah, I think it just provides a really important sort of structure, and I too am optimistic, but we're really now talking about what's the point of care, and it's remission. So we have those conversations now a lot with providers and talking about response and remission, and we're very clear we want to see remission. Response often leads to recurrence. So, the data is really clear about that. So the goal is getting to remission for people that are in clinical categories. And if you don't know if your patient's in a clinical category or not, if they're in a subclinical versus clinical, then we have a problem. And those conversations are starting to take place at this point. They're very interesting and they're varied. They are extremely different kind of for the providers that we're working with, even in our Connect to Care, our curated network. So I've had providers talk about, we want to show you our remission rates, and we've had providers say, wait a minute, I have to use tools beyond the PHQ-9 and the GAD. Is that accurate? And so it really is. But the point is that we're having the conversations, and I think that's really kind of where the progress is. So I want to get to now sort of the role of cross-sector collaboration between providers, payers, digital healthcare companies, and policymakers. How do we all work together? How do these various different sort of stakeholders work together in ensuring that we truly kind of continue the progress that we're seeing now in really getting to outcomes in behavioral health care? So, Deb, do you want to kind of kick us off there?
Sure. And, the digital space is kind of new to behavioral health. We're just on the cusp. I was telling my colleagues earlier this morning that I was in Washington, D.C., and I happened to meet with the NASW. We had something to discuss, and I said to them, from a professional society organization, we really want social workers to do more in measurement-based activities, and they really need to learn about that in social work schools. They weren't taught that. And is this something as a professional society that you can help us promote to your membership? And their response to me was, the lady leaned into me and she said, "You're going to pay for it?" And that was kind of probably, she saw the look on my face, that, yeah, but it should be like it shouldn't be you should pay for it. They should do it, as a standard of care. So
Like a primary care doctor would take blood pressure, right?
Thank you. So we're not there yet, and I know I'm just using one example, but I think that we're heading in the right direction. Digital sources, digital therapeutics are new to us, but we, the payers, need to collaborate with not only the policymakers, but with the providers on doing the right thing. And I know a payment model is important, and we absolutely want to pay for evidence-based value-based care where people are benefiting from, but collectively we have more to go. So.
Brianna, do you want to weigh in there?
Sure, absolutely. And I think some of this goes back to the discussion we had around behavioral health is really an umbrella term. And as we think about specific population cohorts that we and you are all serving, understanding what tools and what measures really help to define those outcomes are important. The PHQ-9, the GAD-7, I mean, these are things that we certainly know about. Does that really mean that we are discussing whether or not someone's life is radically improving? When we hear Christina talking about what it meant for her and her personal journey and whether or not she was getting out with friends and participating in, school dances and things that really help define a young person's quality of life, it's hard to capture some of that through the GAD and through the PHQ. And so what do we do a little differently? And some of that really does depend on the types of care that we're talking about. And so we're interested in hearing what your craft and your expertise is telling you that we should know about and care about. And then how do we really ingest that data? Taft, you talked a bit about the challenges with EHRs. From what we can see, probably about 30% of the providers that we're working with today are using a form of an EHR. We also know that EHRs are the simplest way to adopt measurement-based care into practice. And so when it comes to ease of use and highest inter-rater reliability, it's through an electronic platform. We also know that that's cost prohibitive for some providers, and we're happy that SAMHSA is investing right now. It's not huge money, but there's definitely money out there from policymakers to help funnel the use of EHRs. So we definitely view that to be important. And then it also gets into some of that quality of the data. And so whether that's some of the relaxing that we're seeing around HIPAA alignment with, 42 CFR, I think people have been very nervous about what sources of data have been exchanged in the past. And yet I kind of call it the Swiss cheese phenomenon. There's such missing pieces of critical data that when we're trying to do our work and do it the best that we can, absent from having that whole person picture, it can be a real challenge for everyone to really leverage data and technology in the way that we want that to occur. A couple other comments, I guess, would be we know that there are different measurement-based tools on the market. Some are in free domain, some cost dollars. Like to see a little bit more accessibility coming down the pike when we're talking about identifying a real cohort of tools that we want to use. And we also want to make sure people are trained in how to use them. And so how do we collectively put efforts together to maximize the use of measurement and adopting that into clinical practice? Again, we're kind of operating from assumption that everyone wants to do it. It's a matter of how to make that happen.
So you're really talking about funding like a high tech for behavioral health to support kind of greater adoption of EHRs.
Definitely.
Yeah. Taft, I wonder if I could turn to you and just ask a little bit about, have you had success in getting people to evidence-based treatment, and how have you done that?
I will say yes with an asterisk. From the payer side, and I think Deb, you mentioned this, is we're limited in how much we can direct our membership to certain providers. And so, yes, we have things like, premium networks, narrower networks where, we have arrangements with a group of providers that transmit data. So we do things like that, but it doesn't eliminate the ability of the member to kind of choose where they want to go for care. And, and I think, you said it very nicely earlier, and I'll say it a little bit more directly. We do have a group of providers who market themselves in a way that is not honest about kind of the effectiveness of their treatment and what they actually do in treatment. And so we have, our members, they get a recommendation from somebody that they know, or they see an ad that pops up and they say, this is the treatment that I need or that my loved one needs. And a lot of times it's very difficult to, when somebody says that's what I need, it's very difficult to say, you know what, we actually don't have any evidence that this provider is providing good, high quality care. We'd like you to go to these providers, because as the payer, everybody assumes that all we're doing is directing it to what's financially best for us. So to some extent, through some of these tools of like, working with plan sponsors, working amongst ourselves to determine, which providers are doing, demonstrably good care, and trying to prioritize them in like things like search results. Yes, we have some success with that, but I think it is and is going to continue to be limited by some of these things that we cannot do. So we can't quote unquote steer patients to or our members to particular providers, and that it becomes difficult because we a lot of times we know certain providers are providing good high quality care and other ones are not, and so but we're still limited as long as some of these providers are in the network and sometimes even out of the network to prevent our members from going to the ones that we know or suspect are not providing good care.
Got it. Deb, can I ask you that same question? How is Optum getting members to evidence-based treatment?
So we started doing benefit design to do incentives for members by waiving cost share, by getting our customers to waive cost share where we can. You can't waive cost share on high deductible health plans. You still have to have the deductible in place. But that helps identify programs that will be covered at 100%. And like COEs on the medical side, we all know if we're going to get cancer, where we're going to go for our cancer treatment. Or I used to live in New York City. I said, if I'm ever shot, send me to Bellevue. I want to go to Bellevue. Like, you know where you want to go. But with behavioral health, it's a crapshoot. It's kind of like, you listen to late night television, the guy with the stethoscope and little beard, I tortured them. I called them so much, that late night television ad. But it's very difficult for us to steer, like Taff said. We on the payer side do not have that magic bullet to steer, and a lot of providers think we do. We really don't. Members tend to call and say, hey, is this provider in network? And we say, no, and don't go. They don't believe us. So benefit incentives, I said earlier about cost transparency. I'd also like to do outcome transparency. I think that's kind of the next iteration beyond cost transparency. If we're allowed, there's a lot of regulations, but it's very difficult. People have benefits in and out of network, and they can choose to use them where they want. And then we, the health plan, when we get the call, we apply medical necessity criteria. That's our role, and we approve or not. Not to approve based upon our belief that a provider is, eating disorder. 90% of our eating disorder is in residential facility-based settings. We've moved the needle this much. We can move it a lot more because we know that residential settings are just going to lead to another residential setting.
And this is, my hot take here is that payers and providers absolutely should be steering patients and families to treatment that works and has demonstrable outcomes. It is the best thing for patients and families. I go back to, I'm the daughter of 2 lawyers. These are people who spent way too many years in school figuring out how to really get into the evidence and the data. But most families don't have that training, that time, frankly, to be able to do that. And so they go to glossy marketing materials where, everything looks great. And I think there's still a view that it's more expensive and so it's better. I want my kid to go to a, facility on the beach where they can ride horses. And it's such a disservice to these families. I've talked to so many families who, had this, cycling in and out of ineffective treatment before finding treatment that works and say, I so wish my payer had said to me or my primary care doc had said to me, there is no evidence to support these programs. And we do have evidence about what works in this field. Try this first.
Right. I think it really, just bringing us back full circle, it really comes down to the data. Because from the payer's seat, getting to high performance networks or COEs, you really have to be able to demonstrate that one provider is better. Otherwise, there's the risk of preferential sort of treatment for one provider versus another. And so I'm very optimistic. I think we really are going to be able to get there. And I know that many payers are doing COEs where they do have the data and they can demonstrate that, and where being able to use clinical outcome measurement will be able to allow us to understand sort of where we're going with the providers that are really demonstrating response and remission, and no copays or kind of tying benefits to those plans. So we're running out of time here. I'm going to just go low tech here. I don't see any questions on the iPad, but I wondered if we just want to throw it out to you all to see if there are questions that you might have and any areas you want to hear more about kind of from the panelists.
And while we're waiting for a question, I'm going to make one comment if I can. A number of us, including you, were at dinner last night talking a little bit about this challenge of, I'm going to call it, you can lead a horse to water. And so as a payer, you can help try to direct folks to what we think to be high-quality providers in some discipline or another. One of the challenges, if we have any regulators in the room, let's talk about this as how we can collaborate together, especially on election day. I feel like it would be a good thing for us to talk about how we can work cross-aisle to really solve problems. But I will say that if we have Violet in the room, you were a topic of our discussion last night, and Violet has brought to cultural competence in the provider network a very clear distinction. And I think the thing that we are challenged by at times with as insurers is what we see on credentialing applications is that we work with magical providers who have every expertise possible. And while we think that that is just amazing, that we have such phenomenal folks in our network, it does make it difficult to identify what specialties really exist. And so while I understand in multi-specialty practice that may be a real thing, if you are one human and you are that superhuman, again, I applaud you. But if not, if we can also have data be a little bit more accurate about how to connect people, I think that would go a long way.
Yeah, just to elaborate a little bit more on the conversation, my fantasy is that we would be able to tag, we need a system of sort of a framework for our understanding what demonstrates somebody as an expert or a specialist in delivering kind of the care that they deliver. If you have had the experience of trying to find a provider, let's just say for trauma, how do you know, I've had this with family and friends, how do you know which provider kind of is really experienced, delivers the evidence-based treatment, and has results? How do you see that when you look at a provider directory? How would you know? And payers don't know. We're getting better with some of the certifications, EMDR. We are seeing a little bit of movement there, but we don't really have a standard system for identifying providers and what expertise they bring. So my fantasy is that we would get to, at some point, sort of what Violet did for cultural competence, where there's a tagging system to indicate sort of the provider's level of training and experience, and thereby kind of, display or help members understand sort of what training a provider has. I think about it on the medical side. If you needed a surgery, you often hear people ask, how many hip replacements have you done, or knee replacements, or whatever the care may be. You don't want to go to that provider who's done 5. You want to go to the provider that's done
Someone
500.
has to be first, Dan.
Right? So I think we need that thinking kind of in behavioral health, and I'd love to see us get to a place where we know a lot more about our providers and their expertise. So some fantasizing last night at dinner. So any questions that you all have? Sure, go ahead.
Hey, I'll just speak up. I don't have a microphone. My name's Daniel. I'm a physician by background, but I'm now in the behavioral health space, in the autism space. I have a question for the payers here. So I think one of the big challenges in behavioral health in is there a way to align longer-term incentives for payers with the outcomes that really matter that might take longer than a year? Is that possible?
You want me to start with that one?
Yes.
You used to get insurance and you used to stay with your insurance carrier forever. You don't anymore. In fact, especially in the commercial space and in the Medicaid space, people change companies very rapidly. It's very hard to follow members, especially ABA kiddos, longitudinally. So very challenging in that space.
And yet we understand why you're asking the question. And so maybe there's a way to split the difference. And it is very difficult to see that longitudinal experience. But what we do know is that there are often co-occurring conditions that wrap around a child with autism, and whether the treatment modality is ABA, PT, OT, speech. I think in the shorter term, we can try to do more bundles of care to help sort of make that experience easier, even if it's not longitudinal in terms of years.
Yeah, I actually ended up talking about this at a meeting last week. You know, it's a challenge that is in multiple areas of healthcare, not just behavioral health. Is that, you know, the manner in which memberships are determined and, you know, good fiscal performance or not is determined is fundamentally at odds with the manner in which we know people respond to a course of clinical care with a chronic condition. You know, the same challenges exist with Alzheimer's, you know, with diabetes, hypertension. These are all things that a treatment now has a payoff several years in the future. And with our commercial membership, I think the average length of enrollment is about 2 years. Medicaid, in a lot of states, especially the ones that are a little bit more stringent, it's less than a year. Even in Medicare, which is a bit longer, I think the average length is like 4 years. When I was at Humana, it was a little bit longer. But, you know, like these are challenges when we know that with these chronic health conditions, you don't see the payoff for 2-3 years out to determine, you know, as you know, payers are beholden to be good financial stewards for our plan sponsors, be they private companies, be they the state government for Medicaid or the federal government for Medicare. And so it becomes very difficult for us to figure out or to justify, you know, paying for a treatment where the payoff might be several years in the future if we know that that plan sponsor is only going to hold on to that member for 2 years. You know, and so there is a mismatch, and I think that there probably eventually needs to be a policy solution to how do we address these issues that now, you know, we're seeing high-cost treatments with like permanent genetic cures to lifelong diseases. But that cure, that one-time cure, whoever the payer is at that moment, might be paying like $3 million for something that the payoff is a decade in the future. And so there is a mismatch between what we are beholden to do as financial stewards for our plan sponsors versus clinically what we know is actually the best thing. And so eventually we are going to have a policy solution for problems like this, and autism is one of those spaces.
I think it also moves us to prevention as an industry, and we've done a really good job at providing behavioral health care services when we've identified a need. How do we sort of starve off some of the need and the demand that we're seeing right now through earlier intervention? So I think as really a collective group, policymakers, providers, payers, there's real opportunity to think about how we move further upstream.
I'm also an adult psychiatrist by training and practice. Question to the payers, have you considered value-based payment models where you're looking at physical health outcomes along with behavioral health outcomes? Because early intervention, yes, people will take care of their diabetes, high blood pressure, and everything else. So connecting those as the
Absolutely, yes. It's easy to do when the holder of the risk is the primary care provider. It gets very difficult to do when we're trying to split up, you know, who's responsible for the benefit. Because I have yet to meet a primary care provider that doesn't want to take credit for how good the diabetes is being managed. You know, and so, but, you know, I think we all can say, you know, I mean, it makes sense that somebody who had severe depression and diabetes and didn't care whether they lived or died, that person is not going to follow their 88 diet. they're not going to be doing an exercise program, and they're probably not going to be adhering to whatever their medication regimen is. That depression gets treated, they care about whether they live or die, that person is going to do a better job of managing their diabetes. And so who gets credit for that, and how much credit do you get on the behavioral health side is something that has been very difficult to determine, like for companies like us who are responsible for the whole person health. It's easy when all the risk goes to the PCP, and that PCP has like a collaborative care model. That's what we do with Oak Street Health. You know, they hold all the risk, but they have behavioral health capability within their clinic. It's easy. You know, they figure out how much the behavioral health team gets. You know, but when we have these kind of disparate providers, so we have a PCP, you know, who's referring out to a behavioral health specialist or provider, it's hard to figure out, like, do you get 10%, 20%? You know, I would say, and I'm a little biased, that the behavioral health provider that gets that diabetes on track by treating the depression should get a very significant bump. But there's not necessarily consensus with that, and it's hard to write a contract that kind of dictates that.
Deb, do you want to say anything on that?
Oh, yeah. I'm going to teach everyone a new acronym because you know we live and die by acronyms. TCOC, total cost of care. As a payer, we live and die by total cost of care. So if behavioral is effective, it drives down the cost on the medical side. Therefore, our medical friends can tolerate what behavioral spends. So yes, we are measuring total cost of care.
I'll just say a very simple example of this in a model that we have for substance use facilities. We've added a measure for ensuring primary care follow-up. And you would have thought we were asking for the moon. The thought of that for the substance use facility providers to ensure that people have primary care visits was really a struggle to get that to stay in the contract, but it's there, and so I think it's going to be incremental. It's starting somewhere.
As a proud mom and pop IOP program, I'm a psychologist. You were talking about measurement-based care, we're all into it. We're spending considerable resources on our end. Where do you see in the future managed care and providers working more closely together to build systems out to make it more equitable, more accessible to us smaller?
I think the goal here is to be able to use the internet to the extent that it's capable by some of those transfers that Dr. Parsons was talking about earlier, like the APIs and being able to transmit data back and forth. The more data you're collecting and that you can pass to us, we can ingest that and give you better data back as well. And so it really does come down to that bi-directional sharing that ultimately is where the greatest success will come in. I recognize, and that's why I made the comment earlier, that EHR adoption is not cheap, and nobody's sitting up here trying to tell you that it is. And we're glad to see SAMHSA and others taking this on when we think about really moving the needle in behavioral health care, continuing to see support for investment and/or aggregator options that are affordable for you to buy into really play a critical role.
Yeah, let me just take a minute to say that I think as a company, we talk about a lot of the challenges with our small providers, but they are a large portion of our network, and they provide a lot of care to our members. And one of the things that we found in the data that we can get is that actually the mom and pop providers have fantastic engagement with our membership. Our members like going to the small providers, and we don't have line of sight as to exactly what it is, but like I can guess, I've worked in small clinics before, there is a personal touch, there's that personal relationship that you get from going to a small clinic, with people that really know you, as opposed to, preaching to the choir, like people are logging on, they're having a non-human driven experience until you get into that session with the provider with virtual care. And so there is I'll say an unquantified benefit to the stickiness of treatment with our small providers within our network. And the problem that we need to solve is that we are moving forward with trying to get more data, but we know that that's a crazy expense for very small providers to be able to do. Again, I think this is an area where eventually there has to be a policy solution, because, everybody knows that a lot of money moves through payers. What I think a lot of times is missed is that when you look at the margins of large payers, and you look at the margins of folks that are on the care provision side, it's about the same. We're talking like low single digits. And so while there is a lot of dollars moving through, most of that money is going right back out to the providers who are providing care. And money is tight on the care provider side, it's tight on the payer side, and to get you guys to be able to transmit those APIs requires a significant financial investment that neither one of us realistically have. I think everybody kind of looks at the payers and they're like, well, why don't you guys just fund us to get it if this is what you want? But goes back to us being financial stewards, and like I said, that percentage of margin, it's about the same. So think about how tight your budgets are. Ours are like that, just on a bigger scale. And so I think we need to get to the point to where we have that high-tech act and that financial support from regulators, in order to get you guys to the level that at least the physical health providers were provided support several years ago when they started up meaningful use EMRs.
It's a really good question, and I think we'll see a lot more movement in that area. I think all the payers are trying to figure that out. So I think with that, we'll wrap it up. We're about at time. Thank you so much.